This panel is Beyond Charitable Assistance, Sustainable Strategies for Providing Access to Medications. So we've been talking, history has led us to a point of some reasonable charitable assistance, but the ground is moving beneath our feet. So what are then going to be some sustainable strategies for providing access to medications? Before we get started, I'm going to ask our panelists just to briefly introduce themselves, starting with Jerry. Jerry, name, affiliation, and why in the world you're on the panel like this?
Jerry Anderson, I'm a professor.
With a microphone closer to your.
Jerry Anderson, I'm a professor with Johns Hopkins University, and I was invited.
Reason enough? Jenny.
Jenny Bryant, I'm a SVP in policy at PhRMA and the drug industry part of the conversation now.
Thank you, Jenny.
Good afternoon, everyone. Matt Eyles, Executive Vice President, Policy and Regulatory Affairs at America's Health Insurance Plans. I think I was invited to be the token payer representative, but I'm here because I really want to stop thinking about ACA repeal and replace for about an hour and a half.
Okay. We can't guarantee that, but we'll do our best. All right, thank you. And then Mark.
Hi, Mark Fendrick. I direct the Center for Value-Based Insurance Design at UM_VBID at the University of Michigan. I have been trying to mitigate cost-related non-adherence for at least 25 years. Thank you, Jalpa, for reminding me for how long I've been doing this.
Thank you, Grant.
I'm sorry, and I'm Grant Lawless. I'm from USC. I'm an academic at the moment. I'm a medical doctor by training and a former payer as well, so I guess there's a couple of us at least. And actually, I'm on the board along with Dan of PAN.
Thank you.
And Dan Klein, I think
Whom
I'm
we've met.
here because we're sponsoring the panel.
Okay.
And of course, working with the PAN Foundation.
Thank you very much, Dan. This session is going to go to 2:50 or maybe 2:55, and we'll go to we'll go to audience question and answer around 2:15 or 2:20, just to give you a little heads up there if you're going to gin up a question. Some of the main topics that we would like to discuss in about this order would be first, a question: is the current model of providing assistance sustainable? What's at risk? And by the way, I'll go to you first on that. And the second one's going to be to remind us why there are assistance programs in the first place that the pharmaceutical industry helps us with, and we're going to probably ask Jenny to start that out. In other words, why do you do patient assistance programs, and is your industry thinking a little differently lately about that? Third, we're going to go to that sort of combination that was raised earlier about patient heterogeneity and clinical nuance. Like, what is that? Where do we stand with that now, and how does that bear upon the question of patient assistance? We might start with Dr. Fendrick on that. Next, I want to ask about how do we think about the contrast of chronic diseases and acute conditions where the stream of care and costs can be radically different, and maybe we should be thinking a little bit differently about patient assistance along those ways. Related to that, a thought may be along the lines of how do we think creatively about paying for perhaps those very expensive pharma bio products that get the high end? Are there some are they sort of out of the current box? Do we need to think about that? And then if we have time, I want to sort of bring back two issues that arose earlier today in several instances, which was what happens now with the interesting combination of perhaps regulatory thresholds going down, but price pressure increasing. It may be easier to get something on the market from a regulatory standpoint. Price pressure may increase, and Jenny and others and Matt and others are going to comment on that. So Dan, just briefly now, just remind us with regard to patient assistance programs, are they, as you now see them, sustainable? What is more or less at risk now?
Great question, and one that I definitely lose sleep over probably every night a little bit. So the need is clearly increasing. I think a number of the speakers today, have talked about the fact that the safety net is going to have to grow to keep up with the need, and organizations like PAN are certainly a part of that safety net. We've seen our utilization steadily increase over the past several years. It's more than doubled really in the past 3 or 4 years. And it's really limited by how much funding is available. And in the case of charitable organizations like PAN, it's almost entirely sponsored by the drug manufacturers. And there's a complicated regulatory environment for how that happens so that it's kept arm's length. But it is precarious in the sense that the scheme under which manufacturers are able to support programs like PAN is under a lot of scrutiny these days because of the concern over high drug costs and the relationship to patient assistance. And you know, our concern is that it could be pushed in a direction that makes it difficult for the manufacturers to continue to support PAN and other organizations like PAN at the level that they've been supporting PAN. So
The key word I heard you say was precarious.
yeah, I think there's some worry that the need is going to outstrip the availability of funding, and that there are pressures on the drug manufacturers that are not necessarily directly related to patient assistance, but impact on how they think about supporting patient assistance programs.
And we're going to come back to that with Jenny, among others. Jerry, you've been at a school of public health for a long time, and presumably you look at patients and populations and so forth, and you know very well about the role of patient assistance programs. Where are these patient populations now? Are they indeed at greater risk, and is this something that might break, or is it at least precarious, the way Dan said?
I hope it's only precarious. So
Oh, that's the best case, is it?
That's, for me, is the best case. Let me just tell you a story that it came to me last week. And this was a doctor at Johns Hopkins who's been working on taking care of babies with genetic defects for most of his life, and he's probably 60 years old now. And this is the disease that affects about 2,000 babies a year. So there's like 6 doctors in the United States that take care of this condition. And right before Christmas, a new drug came on the market that could take care of this condition. And he was just the happiest man in the world. And then the price came for this drug. And it's $750,000 for the first year and $350,000 for every subsequent year. Well, you know, we're in East Baltimore. No one. You can buy a whole row of houses in East Baltimore for $750,000. I mean, no one has $750,000 in that. The Medicaid program is very unlikely to do it, and that's where 70% of the revenues come from for babies in Baltimore. And so, you know, they're not going to cover it. So, you know, the question for PAN is, can we ask you for a check for $750,000 to cover one child for 1 year? Absolutely not. I mean, we could ask, but I can't imagine that anybody would say yes. And so we're looking at a whole series of drugs like this, you know, and so for us, the whole issue is one of access from a public health perspective. I could talk about hepatitis C and other things where only 20% of the people are actually getting the drug. So, you know, our concern here is how do we pay for these very expensive, very good drugs? I mean, this is a drug that's going to really help these children, these babies. But how do we pay, and if it costs $750,000? Because we're just not going to.
So there you go. I'll just start to interrupt, but it's already precarious. At the same time it's precarious, there are some breakthroughs that come with some pretty hefty prices. You're not saying that these things don't work. Some of them
work just wonderfully well.
But at the high end, we're seeing a lot more spend for those new drugs. Grant, you deal with issues like this in coverage and so forth. What's your take on precarious? Yes, more or less?
Yeah, it's kind of awkward, I guess, as much as anything, in the fact that, you know, there really are a number of great drugs coming along, and they're very expensive. And assuming it works awfully well and it accomplishes everything it ought to, that I think paying for it does make sense if it does accomplish all of those goals. I think asking ordinary insurance carriers to pay for all these kind of extraordinary products and services is probably not a reasonable approach. So I always thought that, having been a former payer and been a former Amgen guy and now an academic, I guess, at the moment, is that there should be some sort of a stop-loss program, that if we take patients who are extremely sick, put them in a separate bucket, and have that be jointly funded by maybe multiple payers, including government underwriting and all those kind of things, so that a regular insurance carrier, whether it's Medicare, Medicaid, or even commercial, doesn't have to pick up that entire costliness on their own back. So it's kind of like what happens in auto insurance and other areas. You get high-risk groups of people, so that regular insurer can think about the ordinary and can price towards the ordinary, and the premiums stay reasonable for ordinary individuals, and those extraordinary, very small people, number of people, but large costliness of those individuals can be held separately and dealt with as a separate bucket.
So the important point you're making, among others, first of all, you're skipping to question 3, which is fine, which is how do we fix this thing? But what you're pointing out is that the insurance system or systems that we have in place weren't designed to accommodate this stuff. You're offering take it away from that or change something at the margin. That's what you're saying.
Yeah,
Okay.
and I apologize for jumping ahead, but
Sorry.
I mean, I think your comment brought it out in that, when you think about a healthcare system, where the pricing of that healthcare system, whether it's the formularies and the different tiers and out of pocket, or the even premium itself, was created by actuaries. Those actuaries, although wonderful people, are not thinking about it from a patient standpoint, as was mentioned earlier, or even a doctor standpoint. So we kind of have to some degree, try to have a different group of people thinking about pricing on things and making that more reflective of patient and patient needs and the medical needs, and not just something that's mathematically figured out in a blind alley.
Got it. Good point. So, Matt, if you excuse me, back to the question of is it sustainable, though? The first 3 folks that have talked about it say clearly the current system isn't going to continue to work. It's not a good fit. There are more people at risk and so forth. And your health plans certainly cover a large part of the United States population. Payment assistance, patient assistance is a complementary source of revenue. Is it sustainable?
Well, I think if you just look at the data about the rate of increase in patient assistance from manufacturers, I think you'd have to say, well, it's not very precarious. I mean, it has increased dramatically over the past several years, and I think it raises the question of why is this assistance happening? And I know there's multiple different reasons, but certainly because manufacturers find a return on investment to providing such assistance. If there was no return on investment, they wouldn't provide it.
So we can keep going back to the well, expecting that they'll kick in more?
If there's a return on investment for the manufacturer, absolutely.
Find out. Thank you. Mark, you look puzzled.
No, I'm not puzzled at all. There's 2 quick things I'd like to say. First of all, Jerry knows very well that no one pays the sticker price for these drugs, and Medicaid hardly ever pays the sticker price for these drugs. But that's not my real point here, and I wish the congressman were still here. Why are we arguing about the cost of a drug that will be life-saving or life-altering while Americans are investing $500 billion in services that do not make a single American any healthier? So we pay
Half
for
$500 billion, Mark?
It is. We think it's lower, but IOM thinks it's higher. I use it's a number that's well accepted.
It's a big number.
And this idea that Medicaid pays $500,000 hospitalizations for people with a very low likelihood to ever get out of the hospital and so on, the focus on one sector, primarily because patients have a larger role in the payment, the pharmaceutical sector, is drawing so much more scrutiny than the other sectors. And drugs, unlike the other sectors, have to have 2 randomized clinical trials to show evidence of benefit, at least safety and efficacy. The other 86% of our spend in this country do not have to do a single trial of efficacy. So if you are going to apply that scrutiny, please apply the scrutiny to the entire healthcare sector and not just drugs.
Point well taken, but we are also here to understand what patients feel. Where do they feel the pain? And it sounds like they disproportionately feel it when it comes to pharma. Am I mistaken about that, Dr. Fendrick?
No, because the fact is, except for some of the examples Tricia gave earlier, the out-of-pocket limits and out-of-pocket exposure to patients for drugs in almost all types of plans is substantially higher than the other sectors,
Okay, thank you. So Jenny Bryant, here to represent the pharma industry, and it wasn't a long walk for you, I know, from your office. So Jenny, can you remind us where your industry is today with patient assistance programs and what your companies are seeing looking forward? What do they expect, or how are they expecting that the terrain might change and affect their role in patient assistance henceforth? You're on.
You know, I think just stepping back, it's clear that pharmaceutical manufacturers are really focused on issues of patient access to medicines. Despite what you might read in the papers, people get up and go to work every day if they work in the pharmaceutical industry because they are engaged in developing medicines to treat patients, and if patients can't get those medicines, that really defeats the entire purpose. And so, of course, lots of the practices are around trying to assure that there's a return, but there's just I think, also a cultural value about trying to make sure that there's access. And that's been really challenging in recent years. It's challenging in the commercial market, it's challenging in Medicare. And as we see more and more patients who are facing very high deductibles in the commercial market and employer-sponsored plans, that means that they're facing cost sharing that's really kind of taking a year's worth of cost sharing and crammed into a couple of months. It's been a challenge for my companies. And in Medicare, we saw same kinds of patterns, not caused by large deductibles, but caused by the structure of the Medicare benefit. And so I think companies are trying to take a look at what they can do in all forms of assistance, looking ahead, recognizing that there are going to be lots of challenges. I don't think it's a surprise that to the extent we're looking at repeal and replace, that it doesn't look like coverage will be substantially more generous than what we have today, that there's a lot of sense that cost sharing might go up, and that's clearly a concern.
So Jenny,
for
as
companies.
businesses, and a bunch of Fortune 100 companies up there, as businesses, do your companies still view it as favorable not only for access, but favorable to their business life, their bottom line, to continue with or even expand patient assistance? Is that a good business proposition for them?
So I think I could say, I focus on the public policy surrounding the industry, and so individual companies are going to make different calls about what's sustainable and what makes sense from a business perspective. What I can say is that all of the companies are concerned about the trends. They are very concerned about where coverage is going, and I think there is a policy issue here about what the purpose of insurance is. I mean, to Jerry's point, he's talking about a medicine for a very small number of people. We don't need to be moving toward an insurance system that tries to have the patient who needs that very expensive medicine cover the full cost. That really defeats the purpose. And I think where we need to be focused is, do we have the types of insurance mechanisms for spreading risk and sharing risk that will be sustainable in an era when we have many medicines that will have high costs and that will be used by small populations. And so, I think it's an open question whether our risk adjustment systems, our reinsurance systems are really fully up to the task to do that. And I think that's where the focus ought to be, is on how we share risk and how we assess what is a reasonable approach to formulary design and to cost sharing, because I think it's quite clear that where we're going now with cost sharing many times is just an explicit cost shift, and it's not really about trying to send a behavior signal to patients to use a lower cost therapy.
So you're saying focus on risk and formulary design as important mechanisms to address
We need to
this?
focus on making sure that insurance is truly about covering the sickest, and that we aren't essentially discriminating against patients who are very, very sick and need high-cost therapies.
Okay.
We don't do that when they need an organ transplant. We shouldn't do it when they need a specialty medicine.
All right. Matt, are you buying this?
Not entirely. So I would ask the fundamental question: how did we arrive at a $750,000 price as being the right price? If we had a conversation, you told me that the price of that product for that patient population lop 1-0 off, we wouldn't even be having a discussion probably. But because of the nature of the price, which is where all of this discussion starts, we're having to have a debate. I think, when you look at the trends across the industry, there's grave concerns among payers about excessive launch prices, excessive price increases, and I know there are rebates that are part of this, but when you look at the growth of prices just for old therapies over time, and now looking at new therapies and what happens in the market, I mean, it's extraordinarily concerning. So I think, it starts, yes, we want innovative new therapies, everybody does, but at some point, society can't really afford all of them, or we're going to have to find some other ways to pay for them, just given
Okay.
the way that our current system is designed.
Okay, point well taken. Briefly, Jenny, then Dan and Jerry.
So I promise not to go on, but I think we do need to.
We know each other for a long time, it's all right.
I mean, I think it is important to put all of this in some context, and I would just say that there's lots of repetition of the sense that drug spending is completely out of control and unsustainable. And I would point you to look at the federal government's estimates about what's happening with spending on healthcare generally, and look at all other, you could look at all the major PBMs. Last year, growth in drug spending was about 4%. The major PBMs reporting 3%. And the projections are that the spending is going to be 4 to 7% annually. Now, and healthcare spending generally is going to be 6%. I am not saying that there's no problem, but I am saying that it doesn't feel like that is the Pac-Man that is eating the entire healthcare budget, or that is going to require really disruptive change to everything we've been doing today.
Okay, no Pac-Man, says she. Dan and then Jerry, briefly.
Yeah. So I want to reframe this a little bit and move it away from the context of the exceptionally high-priced drug.
You'll have to convince Matt of that, but go
Okay.
ahead.
So PAN, over the past 2 years, provided assistance to 500,000 patients, roughly. The average amount of assistance we provide is around $3,000 a year. So we're not talking about $700,000 drugs. So again, I want to reframe this around the notion that there are a group of people within Medicare in particular, between 150% and 400% of federal poverty level, who have trouble getting access even before they get to the donut hole. So getting through the $400 front-end deductible, getting through their 25% coinsurance, let alone getting into the coverage gap. So by the time you get up to the catastrophic limit, the total spend is around $8,000. So we're talking about total spend, health plan, and out of pocket. So we're not in the stratospheric realm of $700,000.
So Dan, what you're saying then, and I don't know what the distribution is around that average of $3,000, but for many of your 500,000 people, somewhere between $3,000 and $8,000 does the trick. That gets them over. Is that what you're saying? That's what they needed?
Most of our grants that we make are probably in the $3,000 to $6,000 range. And we have, I think, maybe 2 grants out of 55 different disease funds. I think we have 2 where the grant maximums are around $25,000. So the vast majority of what we do
Okay.
is down in the range where, a lot of people who are better off don't need to come to us. The people we're helping are people who are above the low-income subsidy, who, without the kind of help we provide, aren't going to get access to fairly standard drugs. Now, they're categorized within Medicare as specialty drugs because they're more than $600. But there's a lot of drugs that fall into that category.
Okay, that gives us an idea about sort of the distribution of assistance. Jerry, on this?
So essentially what you have is, as Tricia Newman's slide said, there's a number of drugs that automatically put you into the catastrophic amount. And, you have chosen, and I think that's rightfully so, to really focus on the people almost before they get to the catastrophic amount, because you only have a limited amount. But what we don't have is somebody to deal with those people who enter the catastrophic amount. And at $8,000, if you're living on Social Security and you're making $22,000 or $24,000, $8,000 or even probably $3,000 is prohibitively expensive.
Okay.
And so, essentially, and I'll slightly get to the policy selections, but, essentially, when you look at the catastrophic limit, Medicare beneficiaries still have to pay when they hit the catastrophic cap. They still have to pay 5%. And that's, very difficult for them. And what it means for me is a lack of access to those drugs.
Okay, fair point, well taken. Jenny, just, why don't you just lower your prices a little bit? No, really, I mean, they are unprecedented prices. I mean, I'm sure you've seen Peter Bach's figures about how if a new cancer drug comes out tomorrow, newly approved by the FDA, and if all it does is increase progression-free survival by a matter of weeks or a couple months, the going price is maybe $10,000 to $15,000 a month, which is significantly higher than it was a decade ago. So have your companies thought about just kind of responding to this pressure and lowering their price points, or is that not practical?
So the first thing I'd say is actually if you look at real net price growth in 2015, the price growth was about 2.8%.
Net price growth.
Net price growth.
Of cancer drugs?
That's a market-wide number. But so the issue though is that a lot of what you're hearing about on the cancer medicines as well as on others is the list price number. And I think we have an interesting example about what happened in hepatitis C, and that's because those prices have been talked about in the press, essentially. We can talk about them and know something about the difference between the list and the net. And in fact, the net price did come down. The company did, in fact, lower its price.
By about 50%.
By about 50%. But do you know what? The prices for patients in Medicare didn't change.
Okay.
So that's a challenge, I think. I mean, I think the fact
So
that
the market didn't feel that price.
Well, the health plans and the PBMs for sure felt those savings, and those savings, to be fair,
Those were
are
all
used-
government by that point,
Okay.
because the government in Part D is picking up almost all of those costs.
And thank you, Matt. Did you want to finish your point, Jenny, and
I
then?
mean, so look,
Sorry.
those savings are real, and those savings flow back to employers and to the government and to patients through lower premiums. But what didn't happen was it didn't happen for the patient taking that medicine because their coinsurance was still tied to that higher price. And I think that's a challenge. And really the best practice I think we're going to see change in the market over the next few years. I think we're going to see PBMs making an effort, and health plans too, to find ways that patients can benefit from those types of discounts, which frankly are just much bigger than they used to be. There's a lot of fierce negotiation that happens in Medicare as well as in the rest of the market that generates large rebates. That means that sticker price is not really the ideal price from which you want to be calculating.
Okay, so this is an important take-home point then. That list price, that sticker price is typically not the real price. The real price, though, is non-transparent largely, but ultimately that patient still has his or her percentage of what is still a large number based on the sticker price. And that's the hurt, right?
That's the hurt.
That's the hurt. Thank you. Mark Fendrick, we now want to enter the world of what difference does it make that all people are different? Patient heterogeneity, how do we start taking that into account here?
So I'm going to segue that, so say not even you, Cliff Goodman, is going to settle the issue of drug prices, even though Cliff is likely to do that. I want to say a couple things, because Dan and Amy, when I came here last year, I said, if we were able to truly implement a clinically nuanced, smarter type of cost sharing, we would largely put PAN out of business, for which Dan said, I would be happy to have that happen.
Early retirement.
I'm not sure he still feels that same way. So a couple points about this. One, no one wants to be on the medications that Dan and Amy subsidize. So this idea of overuse and moral hazard among the academics here, and particularly in this space, is barely ever seen. So again, the academics say, well, why would you put a large amount of cost sharing on something that patients should pretty much be inelastic toward, or they would pay anything they could. And I think that that has kind of motivated this idea of, in that clinically indicated situation, that's the way cost sharing should be set. And it's my view, as I skirt away from the drug price issue, is that Americans, and Kaiser Family Foundation showed this, do not care about drug prices. They care about what it costs them. And what, I'm seeing some nods, what was really interesting about the points raised earlier is that those two different prices, which were kept separately for the 25 years I've been doing this, are now equal in the world of a high deductible health plan. So I've said to many of you, the EpiPen phenomenon would not have been known if many of those moms who are going to fill their EpiPen this summer had been moved into a new type of health plan that instead of paying $50 when the price was $100, $200, $400, $600, they were now seeing $600, which was not what anyone else was paying. I mean, no one else in the marketplace was saying. So this idea of what it costs patients is what really matters.
Okay.
And I think that, you know, since the congressman is here, I love health savings accounts. I despise the current version of high deductible health plans because it gives no clinical incentive for patients to do the things that I beg them to do. And I think that if we could get around to this type of smarter, which used to be co-payments, Jenny, then it was co-insurance, now it's smarter deductibles, we will now see a slow shift, I hope, to spend more on the good things and less away from this $500 billion that the incentives are currently in place to buy more of.
So Mark, if you go to that more value-based deductible and so forth, or high-value plan as you've described it, does that increase or lessen the net burden on what PAN does, for example? In other words, what does that do about patient assistance, and where does that leave the patient ultimately, and how much they need?
I don't know, Dan and Amy could speak about how many times people are calling them up for unnecessary back surgery, the third MRI in a week, EKGs every year, all these types of things. What my knowledge, the publicly available knowledge of PAN is that I would say a substantial majority nor unanimity of the services they are providing assistance for are services that patients have gone through 23 steps. Their clinicians have argued through 25 types of things, argued on all the straight through that this is so important to them that they will do this, right? I asked Dan, I don't mean to take your prerogative, how often do you see an application of PAN for a clinical service that is not clinically indicated?
And how often is that, Dan?
We're a secondary or tertiary payer in the scheme of things. So Mark is absolutely right. By the time PAN is helping patients cover their out-of-pocket cost, the patient has probably been through at least one, if not several, layers of prior authorization to make sure that the medication they're taking is medically necessary and appropriate. So, I would say that Mark's spot on. That
So I want to tell my version of Jerry's story, which is very important about the brilliant basic scientists who are funded to the billions of dollars to find these cures.
Okay.
They believe that in that terrible situation that we heard this morning, that in my office, I diagnose a patient with a terrible cancer for which they are lucky enough to have a genetic test that is lined up with a genetic marked therapy. Those basic scientists believe that confetti falls in my office and that patient is swept off to that expert, to which that patient gets that targeted therapy. Not that it's hard 23 steps to get the therapy, they get it easily and at no cost to them, right? And then we hear stories about 23 days. The one patient I've met with familial hyperlipidemia, right, who now has a chance to prevent her to be the first person in her family to not have a heart attack by age 40. 23 steps to get the targeted therapy that was designed for her gene, right? This does not seem right. You know, precision medicine, you've heard me say this, Cliff. You know, we have Star Wars science and Flintstones delivery, right? No. Oh. Fred and Barney would be really happy for that. We need to keep up. Who knows the vice president, ex-vice president? We need to make sure that these amazing scientists are understanding that we can't keep up. The fact that PAN is not just on the potentially nervous about feasibility suggests that there's a disconnect that the other people on this panel, not me, and the folks in the audience have to help us do a better job.
Okay, so thank you, Mark. Grant, I'm just kind of wondering though, how well informed are we about the true value of these interventions so that we can make informed decisions about what we're willing to pay?
Yeah, and that's an excellent point. As a matter of fact, a study has come out that looked at rheumatologists, and approximately half of all patients started on RA drugs would do well with just the basic old generic methotrexate, cost almost nothing. But yet 88% of them, 88, start on a biologic when there's no need at all. And those who do start on a biologic, that doctor has no way of knowing if it's even the correct drug. It may have been the methotrexate was the right drug. So as we start thinking about having better markers and having better biologics in order to understand what is the right drug for the right patient, that kind of heterogeneity that was mentioned, we've got to get our doctors educated in the fact that there are ACR, American College of Rheumatology guidelines. Nobody follows them, even their own members. So we need to follow basic guidelines. We need to have clear pathways. And what I was always thinking is that if the patient and that doctor follow the right guideline, that maybe that out-of-pocket should either be minimal or none at all. Because ultimately, you're going to have the best outcome, even if it's the most expensive drug. But it gives you the best possible outcome because you're on the right drug. Then why are we still having a high out-of-pocket if the patient is doing everything exactly right?
That's the high-value option that you're
That's right.
advocating.
And
Okay.
the patient who's potentially taking the least expensive drug, which is the absolutely wrong drug, they're forgiven, and yet clinically they're going to have the worst possible outcome. So if we can take what Mark is always talking about, what I like to think about is trying to align that patient with the right therapy, and then being reasonable in aligning the out-of-pocket obligation with the patient and the physician doing the right thing, that if we could make that somehow line up, I think everybody would win, even if it is very expensive. But everybody's winning, so why not go along?
Okay, so Mark,
We call that reward the good soldier.
Right.
By the way, this is a proposal that is not just theoretical in a brilliant academic's mind. If you go to vbidcenter.org, on the homepage is information that you would see where Star Wars. No, but I need this. This is one of the very few ideas in this country that has bipartisan political support.
that it does.
Stakeholder support. I mean, support from AHIP and PhRMA. I mean, this is you hear that how much these two love one another, but regarding concepts, there's very few ideas for which.
Okay,
they come
so
down
explain this to us, and then Matt, make sure he's telling
really
the truth.
quickly, non-clinician. So
Okay.
I just studied the use of biologics in a database of 14 million people. I did not find anything near to what these rheumatologists said. Most people, thanks to Matt's good shepherding, have to try methotrexate or have a reason why they shouldn't take methotrexate before they get these biologics. And I would say to Amy and Dan that unless a patient has a reason that they shouldn't take first-line therapy, I would not approve patient assistance for a second-line therapy until the first-line therapy fails. Now there is this new type of patient who has a genetic marker who just says, we know now that methotrexate won't work, right?
Okay, but you have to clarify something for all of us. So we're talking about the instances where we're not going to have, if we're smarter about this, we're going to go the high-value route, and the patient doesn't have to pay anything. Who does pay, though, ultimately? Does his plan end up paying in those instances, and does Matt come out ahead? Mark, you can opine on that, which it looks like
I'm
you're
not
going
gonna
to,
opine.
but then I'm going to ask Matt, what do you
Yeah,
think?
so the answer is Matt will be able to tell his plan sponsors for the first time that they are now spending their dollars more on things for which evidence is strong.
Matt, better distribution of your spend, is that the point?
Yeah, I mean, many of our members are some experimenting, some are pretty far down the path in terms of trying to come up with many of these novel benefit designs. And I would wholeheartedly agree with Mark's comment that the HSA framework and construct needs to be updated. I mean, it is built. We are moving towards a value-based system. There's still work, to be done. It is built on a fee-for-service chassis, right? I mean, the old HSA, you can't use your HSA unless you get a service, right? We need to find a way where people that are receiving things of value are able to use the benefits of their HSAs before you get all the way through the deductible if there's real evidence.
Therefore, good point. Now, back to does this not help the world of patient assistance. In other words, if the available spend is better allocated, then when we do need patient assistance, those are better focused dollars. Is that the idea?
I think that's right, and I think another critical point that Dan mentioned earlier is really around the distributional effects of who needs the assistance, right? And when we're talking about income-related assistance, it's very different than when you're trying to provide assistance to the entire universe of people who can afford it and who can. And I think, conceptually, most of our members believe that, especially knowing that we serve Medicaid beneficiaries, we serve Medicare populations, commercial populations, that people who have fewer resources can have difficulty affording access to treatments. And so that's why there are greater subsidies in many programs for low-income people. And in Medicaid, there's almost no copayment, right?
Right.
We have made some of those adjustments, but we need to think, I think, more holistically as a society around some of those adjustments.
So we'll come to Jenny in a second, but Dan, doesn't this sound like something that could really make your organization more efficient? In other words, you quoted earlier today how much money you give out to how many people every year. If we go with high-value plans and so forth, and we go with clinical nuance, and we make sure the right people get the right drug at the right time, like Grant said, then when it's time for you to spend money, you're spending smarter money, right? Doesn't this help your organization's mission?
I think that's absolutely the case. So to the degree that the health plans are using a value-based insurance design, and the patients who are high-need, high-cost patients are not being asked to pick up a disproportionate share of out-of-pocket cost, then they're not coming to PAN. Now, I'm not quite convinced that Mark's going to completely eliminate the need for patient assistance, but I do think he can shrink it, and shrink it in a rational way. And right now, part of the problem is it's sort of an irrational system of cost sharing, particularly with regard to people with cancer, chronic disease, other rare diseases. The other key piece, though, we need to keep in mind is that today within Medicare, you've got a nice natural experiment. You've got the LIS and the non-LIS, and we had a paper last year from Dr. Doshi that showed the use of TKIs within that population, and it was much smaller within the non-LIS population. They're slower to start treatment, and they didn't stay on treatment. And when you look at the LIS and non-LIS just in general, and look at the percentage that reach the catastrophic limit, about 4 or 5 times as many patients who are getting the low-income subsidy are reaching the catastrophic limit compared to non-LIS. And I don't think that's because of epidemiology. I think it's because of cost barriers.
Right.
So I agree entirely with Mark. I just don't think Mark can necessarily deliver on the promise of eliminating the need for patient assistance.
Just one day a week. I want you to work one day a week.
Well, but it is one of the very, very few issues that gains bipartisan support down Pennsylvania Avenue.
So if it
there's
shrinks
hope.
If it shrinks it, it's good.
Jenny, can you live with this, a more value-based healthcare system, which makes tougher decisions about when your stuff works and when it doesn't for particular patients? Can you live with that, knowing that spending will be much more efficient? And by the way, your patient assistance dollars will go further.
Absolutely. I mean, in fact, we are right there. Had an event just this week to launch a new value collaborative that is about trying to drive policies and projects to get us closer to a value-based system. I think our companies are ready to stand behind their medicines, and you have a lot of the companies who are saying, essentially we'll do risk sharing, we'll do pay for performance. We want to be part of the evolution of the whole healthcare system toward one that's more geared toward value. And I do believe that there's a direct link to patient assistance, because I believe that the safety net will be less strained if we can
Right.
be more value-based. We will get better outcomes that will allow for more rational resource.
So the picture is taking shape then for how we might consider patient assistance going forward, especially or even given these riskier conditions. Jerry, you're a keen research-based data guy, observer of this. How confident are you this is going to go forward?
Well, Mark, I think, is doing a great job, but not that I don't trust him.
You shouldn't.
But, you know, who would I rather have making the decision about which drug I get? Mark or my doctor? And my feeling is that I would rather have my doctor making that decision because I think that he or she knows me and what I'm likely to do better. So one of the things that we're moving towards in payment reform is bundled payments. And in most cases, bundled payments do not include pharmaceuticals. They include post-discharge care, they include hospital care, they include physician care, they do not include pharmaceuticals. And for me, the person that I want making that decision, not as Mark, I think he's doing a great job, but maybe he could just provide the information to the doctor so that the doctor, as part of a bundled payment, can make that decision.
Okay, but Jerry, just a bit of a challenge there. We heard this morning from a patient and others that doctors aren't quite ready, and Veena added as well, Shankaran, that doctors aren't terribly well equipped at all to provide information about the cost side. We know that most of those friendly docs about whom you're referring don't have the sort of health services research acumen of a Kai Young or a Jalpa Doshi. So how do we make sure that the doctors in whom you've got such great confidence have the tools, have the information at the ready to make that trustworthy evidence-based decision?
Well, I think, you know, that they are going to medical school, they are getting continuing medical education. They really haven't had to make those decisions in the past.
They haven't.
I think when you give them that responsibility, they will step up to the plate and be able to do it. But that's, you know, that's a guess. But I have more confidence because I think my health situation is different than your health situation. And what Mark and all our data can do is say for the average person, this is what's doing it. I can start making adjustments for men and women and all sorts of other things. But I don't have that same confidence that as a statistician, I can do all those adjustments.
Got it. Okay, in this order, Matt, Grant, Mark, all of whom want to say.
So I think the world that Jerry's talking about is really like a Medicare fee-for-service world, right? I know many of our members are engaged with risk-sharing arrangements and ACO-type arrangements with health systems and providers that do include drugs. And so when they're sharing data and information between health plans and physicians and back and forth, that it really is for the total cost of care, not for every type of condition, not for every type of procedure, but increasingly it is accounting for those types of drug interventions and how do they fit into the total cost of care. I'd say Medicare is a program, while it's made significant strides in terms of moving towards value, is still behind the times, largely.
Behind the private sector. Yeah, point well taken. Thank you very much, Matt. Grant, on this.
Yeah, the term value is probably one of the most widely distributed term I've ever heard. So if you think about it simply for today, is value the most financially prudent drug with a reasonably good outcome? Or is it the very best possible drug for your individual outcome, and maybe it is at a premium price? And I think the argument always falls in that, which choice are we making? Are we really trying to find out what is the very best possible drug for that patient? Or are we looking for one that's going to be a reasonably good enough drug at a very good discount price? And I think there was this craze in managed care over a number of years towards cost minimization. How can I get the very possible cheapest drug? And sometimes that was good enough. As a matter of fact, many times that was good enough. But it wasn't always good enough. And I still see that we're driving towards how can I get the lowest possible price rather than I think what is the long-term value, which is the best possible outcome, particularly in something like a cancer or an MS or rheumatoid arthritis, something like that where you're going to have lifetime consequences. You know, employers are always trying to keep the premiums down as low as they can, and that's great because I think they're trying to protect the affordability of the premium so they can offer reasonably cost health insurance to their employees. But what you find when you look at the data is that the sicker the employee is, the longer they stay. So that if you don't give them good care up front, if you don't offer them the very best drug for the most effective and efficient outcome, they're going to get sicker and sicker, and actually over the course of their tenure cost you more money than anybody else. So there's a lot of kind of conflicting surfaces, if you want to call them that, between that employee who doesn't leave, who's going to get sicker and sicker, and trying to save a buck today because your premium is based on this year's spending.
Point very well taken. Thanks for that, Grant. Mark?
So I'm going to just briefly clarify, Jerry, what we're doing is exactly the opposite of the average approach. So there are drugs, like many people might have heard the term beta blockers. Beta blockers are cost saving in people with heart failure. They're cost effective in the setting of hypertension and angina. They may be wasteful in people who take them for performance anxiety. But the idea that, as Kai Young was talking about, the next stage of the value-based formulary is not just saying a class of drugs should have a separate cost share. We use the $5 billion of EMR investment that we've only used thus far for cost share, for charge capture, as opposed to helping our patients, to really move this idea of precision medicine forward. But I think the key point talking about, under no circumstances would anything that VBID or alternative payment models want to get in front of the clinician and the patient. We would like to think, as someone said, that evidence is used to the highest level of value, but this is coming, Cliff, the peanut butter and jelly story here, that the key levers in healthcare transformation to value in this country is not the demand side, the patients. The key levers are the providers, and we have made great progress with bipartisan support to move from fee-for-service to something else. I'm not going to say bundles are better than global caps or ACOs or MOUSEs, but I'm saying moving away from the abomination of fee-for-service is a good idea. And I would basically say why clinicians now care about what we're doing on the benefit side is because now my colleagues in primary care are getting part of their bonus based on how many of their diabetic patients, not everyone, of their diabetic patients go to the eye doctor every year. It turns out the fastest growing type of health plan in this country, an HSA HDHP, doesn't cover at all a diabetic eye exam. So the clinicians are now seeing their bonuses tied to a crappy benefit design and now saying, I want to align clinicians, peanut butter, patients, jelly, right, and have them in this classic example of the sum being greater than the individual parts. So the providers have moved in that direction. Currently, the love of HSA high deductible health plans are actually putting an obstacle in place of a 20-year bipartisan movement to create more value in the healthcare
So
system.
to clarify, though, and this will come back eventually to patient assistance, the high deductible health plan is a barrier to what can be highly cost-effective care for many patients, including a lot of patients with chronic diseases. You would keep the deductible in place, but not for certain things that are clearly beneficial. You'd set it aside, and there would be no deductible for those services.
Here's my line for Matt. I love high deductibles. Here's my line for Jenny. I want deductibles only to apply to services that don't make Americans any healthier, right? So I'd like to blame PhRMA or AHIP or other stakeholders. The constituent in the current bad policy are those dreaded health policy lawyers at the Internal Revenue Service, who in 2004 created something called a pre-deductible safe harbor. Those services that might be covered, some first dollar, but some with cost sharing, before the deductibles met, $6,000, $12,000 on the way up. It turns out that those wise health policy IRS agents put in a bunch of primary care services, screenings, counselings, immunizations, but they explicitly excluded any service to treat an existing injury, illness, or condition, which is 100% of the requests that Dan and Amy get.
Right.
Right? So
That's the disconnect.
We have proposed for 10 years, now have multi-stakeholder and bipartisan political support to allow plans to voluntarily expand the pre-deductible safe harbor. And this is something that Marilyn Tavener supported in her blog post Monday. We know Jenny's organization has supported for a very long time. Because it's voluntary nature, right? It gives these plans a chance to spend dollars better in the health plan spending, the health savings account spending, and hopefully reduce the amount of applications that Dan and Amy get.
And Matt was just nodding his head. Are you with that, Jenny?
I am with that.
I'm leaving on a high note.
And I think Mark knows that. I was going to actually pivot, though, and say that, you know, in the Medicare context, as we think about Medicare Part D and about the challenges here, since that's so much a part of Pan's world, the sort of analogy to the problems of high deductible health plans is the specialty tier, which, again, is sort of placing high cost sharing on medicines in an arbitrary way without the ability to have a patient seek an exception, even when it's been prior authorized by the plan, they've gone through step therapy, it's absolutely the right medicine because they have a genetic marker for the medicine. So
Yeah.
I think that's an example of where Part D could be modernized to be more value-based.
Well, point well taken. In a few minutes, we're going to go to your questions. Don't be shy. These people can handle it. So if you got a tough question, let them have it. And you stand between them and the door anyway, so you'll get an answer. Dan, on this.
So, you know, in the context of this solution that is emerging from Mark and our colleagues from the payer community and the pharma community, the issue for PAN and other safety net providers is we're just suspicious that they're going to still be a group of people falling through the cracks who are going to need assistance regardless of how intelligent the benefit design is, value-based or whatever comes beyond value-based. And the reason I say that, again, goes back to sort of thinking about Medicare Part D with the low-income subsidy and the non-LIS and the differential in utilization. So we know that income or means-tested kinds of programs are pretty hard to get through public policy vetting, and they're not really part of typical insurance design. And in many ways, what the patient assistance programs, at least the charitable programs like PAN, provide is a sort of means-tested high-risk pool. I mean, we do means test. We do look for people to be at or below a certain level of federal poverty level. And then we do provide assistance. Now, we'd much rather narrow that assistance that we provide to just value-based
Right.
treatment, cost-effective treatment. That would shrink the demand, if you will, the need, but it will still be there. And I think that the question, or one of the questions being asked today is, longer term, what is the role of patient assistance and how do you sustain that? And when I talk about it being uncertain right now, it's uncertain in the environment where it's been growing and growing and growing and growing and expected to grow. And I think we're hearing that some people are getting nervous about that.
Some people are getting nervous, but we've heard a couple of reasons why we can be optimistic, one of which is if the system becomes more value-oriented, whatever dollars are available, as I understand, for patient assistance will be better spent. Jenny's companies are not showing any signs of backing off this, and as Jerry would point out, it might even be helpful for their bottom line to continue to do so. Any questions at this point for the group? Yes, name and affiliation, please.
So, Kai Young, Group Health. So my question is for Jenny and for Matt. With regards to this growing disparity between list prices and price net of rebates, and how that impacts negatively patients on high-price specialty medications, my question is, why do you think that is happening, and could potentially increases in pricing transparency with regards to this net price be part of that solution?
I'll start. So, I mean, we know that over time that there has been a growth in rebates, and some of that's due to the way that plans and PBMs negotiate. It depends on the level of competition within a particular therapeutic class. What I would be mindful of, so we are supportive of certain types of transparency, but I think if you are going to have to publish what rebates are at a particular drug level, I think that that's actually counterproductive. I think there's been good analysis that's been done by the Congressional Budget Office and others that indicate that that's actually going to increase costs. I mean, of course, we'd like to see prices start at a lower level rather than a higher level. I don't know that there would be as great a need for rebates and discounts in the system, but we do also know that there are efforts by plans and PBMs to look at this particular trend, and are there ways to create different benefit designs and ways that at least a portion of that flows through. So much of it is complicated as a result of the way that the rebate system is set up, mostly retrospective, that you have to meet certain performance targets before you figure out what your rebate is. So I mean, there's a lot of different complexities there. I don't know that transparency of the net price actually helps matters at the end, and we'd be very suspicious of that.
Okay, thank you. Jenny, on this issue?
So I think that I would sort of agree with Matt that that transparency about that net price is less what's needed than ways of making sure that patients are really benefiting. And that is a really complicated process, and I think there are a lot of folks in the market who are beginning to try to think about that in creative ways. So I see manufacturers and PBMs and health plans all sort of working on that problem. So I think that's where I would be. There's been plenty of evidence that if you actually publish the exact net price of a transaction between a specific payer and a specific manufacturer, that that level of transparency drives up prices. It doesn't drive prices down. So we don't want to create problems that way. And I think that's been the consensus of CBO and other economists. At the same time, we clearly do need to find some ways to make sure that the rebates are really flowing through the whole system. So I'd say this is an area of ongoing thinking and policy development.
And just for a good doctoral dissertation. Yes, Jerry?
So essentially, I think, you can't say exactly how much Pfizer sold it to Anthem or whatever for a particular drug or for particular Express Scripts. I mean, I think we could all agree, or most all of us agree on that. What you can do is much more transparent on the average net price that's out there, because that's what the consumer is paying, and that's essentially what they need to know in deciding drug A or drug B. Not the list price is what they've got, but the price that is close to what's being paid. That's the information that I think we all want.
Get in the ballpark, yes. Any further on this particular issue?
Only while you're in the deductible. Remember, Americans do not care about drug prices. They care what it costs them. And if we didn't have this rise of high deductible health plan, I totally agree with Jerry, because now the price of the drug is the price the patient's paying.
Yeah.
When we start changing the deductible and the cost sharing thing, then they'll just be totally happy to pay their $50 for their EpiPen.
How hard would it be to get enough information from individual patients to be able to make real-time decisions about what this next drug decision is going to cost them? This next prescription.
So
Can't we do that yet?
Really quickly, I don't think most people view Medicare or TRICARE as particularly nimble organizations. You heard this morning from Kai, so the VBID-MA demo is now in 10 diseases in 10 states. Grant will agree with me, Matt will agree with me, most plans know who their diabetics are, their heart failure patients are, their depression patients. They've been collecting this information for decades. So I realize that they may not be as nuanced as Jerry wants, but it's better than the average population. So Medicare, 10 diseases, 10 states, bipartisan support to expand that condition-based concept to all 50 states. The TRICARE program, viewed as the least nimble, President Obama, December 27th, signed the NDA authorizing a large VBID demonstration in the TRICARE program, again, condition-based. So I'm not the person who does these things, but the fact that those organizations, on top of hundreds of private self-insured employers who've done this type of thing, suggests that it's not just a crazy idea anymore.
Thank you. Andrea,
Yeah.
question.
Yeah, thank
Re-identify yourself, please.
Yeah, Andrea Baer, Mended Hearts. My question is, short of, and this may sound kind of, it's not an antagonizing question, I promise. short of a single payer healthcare system, which we all can disagree or agree on, what is going to be the sustainable solution to make sure that patients, regardless of their income, are receiving a quality health care? I can tell you through our organization, we see patients who have the money to pay these high premium deductible or high premium costs for their health care are getting way better care than people who are stuck in the Medicare system or the Medicaid system where their choices aren't being made by their doctor, they're being made by their insurance company. So short of one system, what are we going to be able to do to be able to assure that how much you're paying for your health care doesn't really regulate what your health care is providing you? Does that make sense?
Grant, is there in fact, from your standpoint, a relationship between how you pay and the quality that you receive?
Well, yeah, I was going to say I'm probably the only one dumb enough to raise his hand, right?
Sorry.
I mean, you're asking the kind of the universal question of all questions, you know, how do I get good medical care? But one of the things that has been tried is something called clinical pathways. And it started in oncology and it's gone into other areas as well. And the idea is let's snip off the low-end stuff that doesn't work. It's inexpensive, but it doesn't work. And the very high-end stuff that costs a lot of money and it's just not worth it. And try to follow a standard cookbook kind of a pathway in oncology. And that generally was fairly well received. It hasn't quite grown as much as I imagined it would, but in places it's been working reasonably well. So there are those kind of pathways. And one of the things that I had in my prearranged notes, which I haven't pulled out yet, was something similar to that once you get put into that bucket of catastrophically ill, and I don't care if it's muscular dystrophy or it's MS or whether it's cancer, it doesn't matter, that there becomes kind of a standard playbook that you follow. And these clinical pathways are kind of the forerunner for that. I also think that once you get put into that bucket, and whether that's by your total spending or whether that's by your severity of illness, that you then get into a capitated out-of-pocket obligation as well. I can see there being a needs analysis on what you pay in your premium, but once you become sick, to continue to have you pay more because you can is kind of punishing you for being sick because you can. And if we could kind of get away from that and put people into these standard buckets, some like clinical pathways, but across a lot of areas, and that pathway would not only be clinical care, but financial obligation, that might be the beginning to kind of get everybody under one corral. Just a thought. I'd love to hear anybody else. Yeah.
Good tool,
A little
thank
bit
you.
of it, and building on that, so you've got the clinical pathways, now you've got to get the economic incentives to actually follow those clinical pathways. So, you know, a long time ago I helped design the DRG system, which essentially put all the hospital services into one bucket. And now we're doing bundles, we're doing managed care, we're doing a whole series of things. So what we're doing is taking these clinical pathways and giving some provider the incentive to do the thing that's probably as clinically appropriate as we can. So the more that we put things together and give people financial incentives to do the right thing, I think that's the direction that I keep moving in.
So thank you. There really is a chain there of reasoning in answer to Andrea's question, though it's a system-wide one, which is collect data, build evidence, gain a knowledge base, translate it into clinical practice guidelines, which can often be transformed into pathways which are more specific. And then you got the pathway, but you have to make sure the incentive's in place to actually use them. So there is kind of a chain of stuff that actually starts with real data and not just opinion. So point well taken. Question back here on the aisle, name and affiliation, and we'll, yeah, go ahead.
Hi, John Beckner with the National Community Pharmacists Association. Historically, one of the biggest barriers to access has been a fairly cumbersome prior authorization system. Is there anything currently being done to address that, make it better, make it more efficient?
Sure. I mean, there are efforts to be able to do electronic prior auth. I mean, I don't want to say it's widespread, but I know within certain plans, PBMs, and others, especially with the growth of EHRs and other technology, that that there is the ability to do some electronic prior authorization. It's not everywhere, and it also depends on the level of complexity of the therapeutic area. It depends on the level of system that a provider might have to be able to provide that real-time clinical information so that a plan could do essentially prior auth at the point of prescribing. So I'd say it's happening, but I think there's still more that needs to be done there.
Good.
I think
Thank
it's
you.
an effect of fee-for-service medicine, in that the more you do, the more you get paid, and so that's why you need the prior authorization. You change the financial incentives, and you can, essentially, I would say, do away with prior authorization, but you can reduce the prevalence of prior authorization if the incentives are different.
That's a great point.
Yeah, but most physicians don't make money prescribing drugs outside of Part B. So I actually think, I want to agree with Matt. The electronic, so, this multi-stakeholder group in the room needs to get behind the fact that the investment we've made in EMRs have been woefully underutilized to take care of patients, right? They have done a great job to take care of people who are trying to maximize their billing and efficiencies. So imagine not only a prior auth that may tell you that you're doing something that you shouldn't be doing. Imagine your EMR telling you, sir, a pharmacist, that a patient's A1C remains high despite the use of multiple generic medicines, and the only alternative is a branded drug that I have to have a prior auth to. Imagine that EMR removing that prior auth when the drug is clinically indicated, right? So the EMR is really key, and there's some really advanced folks around the country, Scott Weingarten at Cedars-Sinai, among others, who have really started to think about using the EMR to provide the efficient.
So we are on the verge of being able to do that in a practical basis. Back corner, yes. Oh, hi. Hey, Jalpa. Go ahead.
Hi, Jalpa Doshi from the University of Pennsylvania. I wanted to make a broader comment, but since that comment came up, I have another question first before I make a broader comment. And so the question is to Matt. To the extent if we are streamlining prior authorizations that Mark, as you were pointing with the EMRs and everything else, here's a slight twist to the value-based insurance design idea where we kind of design either clinically nuanced value-based formularies, or what Jerry was mentioning earlier, that, do I trust my plan to decide what's best for me, or do I trust my doctor to decide what's best for me? And my point is that once a patient qualifies through a prior auth, so the physician has filled out a form and has demonstrated a clinical need for the patient that this drug is needed, at that point in time, why couldn't we waive co-payments or lower co-payments for those patients? Because then it makes Jerry happy, it makes Mark happy, and most importantly, it makes the patients happy.
We want to make all of them happy. Mark?
This is reward the good soldier. So again, you all see that VBI, just Google VBID. The first thing you'll see is that this is not just a brilliant academician from the great University of Pennsylvania. There are organizations, some in the room might want to speak up, that have their own benefit designs say that if you fail a low value therapy and the evidence says that this, what one time was a high cost, low value therapy, but because the low cost therapy doesn't work, it becomes a higher value therapy, it should be encouraged, not discouraged.
Right, Mark. And my point is, my question is to Mark.
AHIP supports it. No,
so
they
why
support it.
aren't we seeing more plans do that? Right now, for PCSK9 inhibitors, providers have to fill out 5 pages worth of forms. They have to fax in every medical record for these patients, jump through hoops. I've heard Steve Nissen talk about employing a full-time cardiologist just to process the prior authorization form. So once that's taken care of, why can't we have that FH patient access the drug for a low-cost share or no cost share
Matt.
for that matter?
I mean, it's, I don't want to say it's ubiquitous, but it's happening. And we're moving in that direction, and perhaps the systems that you're working with, or the plans perhaps in your backyard, have not gotten that far. But it's happening. I think all of us want to see more progress faster so that we can move towards these value-based benefit designs. But it's both the systems build by making sure that you have the records and the infrastructure. Not to make excuses, it's taking longer, I think, than all of us would like to see it take.
Good thing. Before you go on, Grant, on this point?
Yeah, I've got a comment for the general audience as well. Medicine is not linear. Your diseases don't always follow a straight line. So there is a value in having prior authorization, because the disease state may go into remission, it may accelerate, it may go sideways, all those kind of things may happen. And if you don't have a touch point every so often, it doesn't have to be 15 pages of paperwork. But if you don't have that built-in touch point for a number of diseases, you lose the opportunity to maybe change therapy, delay therapy, even increase therapy. So it's not always just about cost savings and managing money. Sometimes it's about managing patient outcome also. So it's not all bad.
Thanks,
We
Grant.
call this dynamic benefit design. That 98% of Americans are in, particularly for drugs, in a set of tiers that are static. And the fact is that just about every chronic disease for which Dan and Amy deals with, these diseases change over time. I'd like to think that that most of them actually get better. Most of them slowly progress. You need to add medicines in just about every one of the top 10 diseases that we're dealing with in the Medicare Advantage VBID demo, which is why we want to see these dynamic cost-sharing things. We don't want everyone to get, Cefakilimol or Cancer Killimol first line if there is a lower cost effective therapy to try first, such as the methotrexate example.
Thank you. Jalpa, are you ready to give up the microphone? You have it in 2 hands now, I see.
I actually got digressed because of that comment, but I really
Oh.
wanted to make an overarching comment, and I will just take 2 minutes.
I'm sure it'll be brief.
Very brief.
Thank you.
And I think that the main comment that I wanted to make was just having sat through this all day and having been thinking about this for many, many years as part of my academic career, this particular issue, it's extremely clear that at this point in time, we need every stakeholder in the system contributing to a solution. Mark very nicely said, what matters to the patient is just not the drug price, but it's what their out-of-pocket price is. But we know what the out-of-pocket price the patients face. Every stakeholder in the system has a role to play in it. That includes providers, it includes pharma, it includes health insurance companies, and it includes organizations like PAN Foundation. Okay. And hearing what Dan Klein had to say earlier about helping 500,000 Medicare beneficiaries over the last 2 years, the kind of data that we presented this morning in the Medicare population and the studies we have ongoing in our team, and to the extent, I don't know if the congressman is still here, the question I really have is, why is it that we treat our older Americans so badly?
Thank you, Jalpa. Do you want to take that as a rhetorical question, or do you have a hard answer to that?
I'm just going to say that my point here is, I think we all should contribute to this solution because it's for our parents, it's for our grandparents, and in fact, it's for all of us because we're all coming down the pike.
Thank you very much.
Thank you.
Point well taken. Nicely stated. Any other question from the floor? Any final? A bit of challenge? Yes. On the aisle. And your name and affiliation, please.
Yes, hi, Susan Thornton. I'm the CEO of the Cutaneous Lymphoma Foundation. So we're a small rare disease, and this has been a fabulous day. So thank you for holding it. But one thing I would say is that I always see missing the patient organizations, and everyone talks about patient-centric and the importance of the patients. I don't see any patient organization represented on this panel. And I know we're all in the room, and I think we need to be stakeholders at the table as well, because there's always somebody that falls out of the clinical pathways. There's always an exception. So how do we make room for that as well, so that these people don't fall through the cracks, because they fall through the cracks every day. And we're here as professionals to be able to help that and to bring those stories to the table so we can make sure that doesn't happen in the future.
Okay, thank you. I don't think there was a question there, but your point was a strong one. We appreciate it. We did have a bunch of patient representation earlier this morning.
Can I
might
ask
say.
a question back? If
Grant,
she's going to ask us questions, I'm
Go
going to
ahead.
ask you a
Bring
question.
that microphone back to the woman in the aisle, please.
So if
she's
they
going to
fall
need it.
So if they fall through the cracks, what's your ratio between the clinical cracks and the administrative financial cracks? Where do you see the biggest failing of those bodies?
We don't know, I would say, because in my world, in a small rare disease with 30,000 people diagnosed in the US and a small organization like mine with 6 people that cover the world, we don't have the capacity to be able to collect the data. So we work with PAN when they have a program open for our patients, which we don't and haven't for the last year. So I don't have the capacity, so we need help to figure out how to capture that data so we can better report on it.
Yeah,
Okay.
so
Mark?
my answer to that, I support engaged patients. I support accountable consumers, whether you're a rare disease or a common disease. You all, so I view myself as a patient advocate, you have to fight against skin in the game when skin in the game is determined as making you pay more for everything. Right?
Agreed.
So, as the Congressman walked back in, I love the idea of an engaged, accountable consumer, but I do not want my patient who had a free mammogram or a free cervical cancer screen, as we have an obstetrician gynecologist here, to send me an email, thanks for this free screening, I have to take out a second mortgage on my home to get the recommended chemotherapy for my specific cancer, right? So skin in the game is a term in this town that started out 10 years ago with good intentions, but had been tied by some scrupulous consultants to high deductibles for everything. And that's where I believe the cracks are, and they're only going to get worse unless we fight to close them in a nuanced way.
Yeah, no,
Okay.
and we will try to help however we possibly can, in addition to doing what we do every day to try to direct people to the right.
Thank you. Was there a last question from the floor? Front row. Name again, Mary.
Hey there, Mary Richards. This is really interesting, and I think the skin in the game thing gets to all of the organizations that I work with. Patients are increasingly financial stakeholders in their own healthcare, but when you visualize the conversation, I think that we idealize between a patient and the doctor to have a conversation around the right treatment at the right time, but we also need to sort of, I picture 50 people in suits behind each one of those human beings, because you also want the right health insurance for the right conditions that you're facing, and you also need the right outcomes data. And I don't know that those two human beings in that moment have that kind of access to information. We're trying to figure out the right way of being financial stakeholders who then also influence the institutions that we're paying money to, that are rewarded by trying to give us the care that we need, whether it's a PBM or a drug company or a biologics company or an allied health professional. So my question, I think, to the panel is, as we all are financial stakeholders in healthcare at this point, each one of us, how is it that there is an appropriate engagement to connect the right, I think, data in general with the folks who can best use it? So I think that the electronic health records conversation is an important one here, but is there a way to empower patients as well as their providers and everyone in the system to have the right information about each other at the right time?
Okay, so what else can we do to put the information at ready access to the patient when she or he needs it, at a level where it is fully comprehensible and actionable? We talked about the EHR just a bit. Jerry got an answer to that one?
So I think, basically you want the patient to have the incentives, but I think you want the provider to have the same incentives. And right now, we have it so that the information might be available, but the doctor or whomever doesn't always find it useful, the information we're providing. And mostly because they don't necessarily have the right financial incentives to get the right information. So again, coming from my perspective, which is from an economics perspective, I want to make sure that the provider has the right incentives to pay attention to the information that he or she is going to get about the patient, and the patient has the right incentives as well. And I think then the data will flow from that. We have lots of data. Most of the time, the data that we have, we don't use because it's not all that valuable to the person making the decision.
Got to be the right data.
So-
Thank you.
so
Briefly.
Upton Sinclair said it's difficult to get a man to understand something if his salary depends on him not understanding it. So you and the other patient advocates in the room, fee for service must go. More is better must go. There is more than enough money in the system. Transportation doesn't argue that, defense, education. We just have to change the conversation from how much we spend to how well we spend. And the more the how well is to set on patient-centered outcomes, the better everyone is. The clinicians will make as much money, the health plans and the health sciences companies will make the same money, but we'll finally, for the first time, set our metric to health as opposed to other things, which has been lost in this conversation.
Thank you very much. So here's what we're going to do now. We got a closing question. We didn't plan this. So Dan Klein is holding his next governing board meeting, and one of the breakouts during that very nice day on a Sunday is a strategic planning meeting. And you've been called in as an outside expert to provide your one kernel of golden advice to the strategic planning effort of the PAN Foundation to their governing board. And you have attended this meeting, and you said or heard something that they need to make sure they incorporate into their strategic plan for, let's say, the next 5 to 10 years. And you only have a sentence to say it. So Jerry Anderson is going to set the great example of how to provide a golden kernel of advice in one sentence to the governing board's strategic planning group. And that advice is what, Jerry?
So are you going to focus on a lot of small dollar items, or are you going to focus on a few very expensive items?
His advice is in the form of a question, because as we know, those few items that are very expensive can really be awe-inspiringly and budget-breakingly expensive. Thank you, Jerry Anderson. And we've got Jenny Bryant next with her kernel of advice, the strategic plan.
I think I would say that to the extent that patient assistance is really about a safety net, no safety net can survive if every high-cost patient falls into it. And I think that what's important to be thinking about strategically is how to make sure that, especially as we look at the Medicare benefit, that there's a lot of attention to helping that move in a value-based direction so that patients who need the medicine can afford it, and that we don't allow plans to be assessing cost sharing, which will force people into the safety net for medicines that they absolutely need to be on. So that's about specialty tier appeals and exceptions.
Another great bit of advice. Thank you, Jenny Bryant. Matt?
So I'd say make sure you're investing in the right data analytics to understand exactly what's happening to the patients that you're serving.
Aha. Got to get that feedback too. Thank you, Matt. Mark?
The more you support clinically nuanced payment and consumer incentives, the better you'll be able to function as a true safety net organization.
There you go. Thank you, Mark. And Grant?
I'm going to say always listen to the wisdom of patients and patient organizations. They bring a lot of insight that we might otherwise miss.
Thank you very much, Grant. Dan, can you live with this advice?
I appreciate all of the advice, and we have these conversations with our board members like Grant, regularly. So we do take a lot of the advice we get, and we either use it to improve our program, or we try to use it to advocate for a stronger safety net. I will say that there's an important distinction to make between all of us being financial stakeholders in our care, which I don't think there's a big argument about. I think back in the day of the RAND study, that skin in the game was $5 or $10 or $15 as opposed to what it is today, and so there was a different meaning when the idea was developed. What PAN's concerned about is not financial stakeholders, that patients are financial stakeholders. We're concerned about patients becoming financial casualties, and that's really the issue for PAN. And we are able to do a lot, but we're not going to be able to keep up with the need. So we do need to find other strategies.
Good, thank you. In a minute, Amy Niles is going to come up to for a few closing remarks, but before she does, this panel has been extraordinarily but not surprisingly full of candor, and they have faced up to the toughest issues, answered some very difficult questions, and all in a constructive way which flowed into the best strategic planning advice you're going to get for free in a long time from the top people. So Jerry Anderson, Jenny Bryant, Matt Eyles, Mark Fendrick, Dan Klein, Grant Lawless, thank you very, very much. It was great input. Thank you very much. Thanks.